শুরু করো।
করতেছি তুষার ভাই, আমি সিগন্যাল দিলে শুরু বলেন। 2 মিনিট। তুষার ভাই শুরু করতে পারেন।
Assalamu alaikum, respected physicians. Welcome you all in today's webinar, ECG Basic and Beyond, on behalf of ECG Study Group. Today is our 31st lecture on case studies on ECG, and today our presenter is Dr. Khondoker Asaduzzaman. I'd like to request Professor Abdul Wadud Chowdhury sir to introduce Khondoker Asaduzzaman sir, say some words regarding Khondoker Asaduzzaman sir, and then we proceed on the lecture. Wadud sir, assalamu alaikum.
Good evening, everyone, and assalamu alaikum. Today we are going to hear some interesting cases with ECG presentation from Dr. Khondoker Asaduzzaman. Asad is an academic through and through. He is now working in a private hospital, but he had been in the government sector, and an interventionist and a dedicated radiologist. But in his interest in clinical cardiology, particularly on the ECG, is well manifested by his regular attendance in our sessions, regular participation, and active interaction with the audience. I hope today Khondoker Asaduzzaman, who has been known as a dedicated interventional cardiologist, will show his charisma as a clinical cardiologist as well by showing interesting ECGs with case presentations. Asad, the field is now yours. আসাদ, তুমি এখন শেয়ার করতে পারো।
স্যার, আসাদ স্যার শেয়ার করার আগে আমাদের 21 তারিখ সম্পর্কে যদি জিনিসটা একটু বলেন আপনি।
হ্যাঁ, আতার ভাই এটা একটু ঘোষণা দিয়ে দেন আর এটা দেখা একটু লাইনে। আতার ভাই বলেন।
আসসালামু আলাইকুম স্যার। স্যার, ওই যে বলছিলাম যে আমাদের স্যার যে আগামী 21শে ফেব্রুয়ারি উপলক্ষে একটা কুইজ, এটা জাস্ট আমাদের কুইজের একটা ঘোষণা, যাতে করে আমাদের সব পার্টিসিপেন্টরা এটা জানতে পারে যে এই কুইজের স্যার ইসিজি গুলো আমরা কালেকশন করছি, রেডি করছি। তারপরে এটা কয়টা যেন 15টা ইসিজি হলে ফাইনাল এডিটিং এর জন্য আপনার কাছে পাঠাবো স্যার। তারপরে আমরা এটা প্যানেলিস্ট এবং জাজ ঠিক করব আর কি। তো এইটা স্যার আমাদের এই মানে আমাদের প্রায় 1 বছর হয়ে আসলো, আর এইটা হচ্ছে আমাদের এই 21শে ফেব্রুয়ারি উপলক্ষে একটা কুইজ কম্পিটিশন হবে স্যার।
কিন্তু এটা করব কবে?
এটা স্যার ওই যে ওরা স্যার অ্যানসার গুলো আমরা ইসিজি গুলো আপলোড করব স্যার 21 তারিখে, 21 থেকে 24 তারিখ পর্যন্ত ওরা অ্যানসার দিবে, আর আগামী 27 তারিখে স্যার 27 তারিখে স্যার এটা ডিসকাশন হবে স্যার।
ওকে, ঠিক আছে, ঠিক আছে।
এটা সবার জন্য যারা ইন্টারেস্টেড, আমরা 21 তারিখে আপলোড করার পর থেকে আমরা এক্সপেক্ট করব যে আনসার গুলো আসা শুরু করবে। 24 তারিখের পরে আমরা কিন্তু আর আনসার অ্যাকসেপ্ট করব না। 24 তারিখ রাত 12টা নাকি আতার ভাই?
হ্যাঁ জি জি, না ঠিক আছে, রাত 12টা। হ্যাঁ জি,
রাত 12টা। তারপরে কিন্তু আনসার অ্যাকসেপ্ট করব না, এবং তার থেকে যে সবচেয়ে পয়েন্ট যারা বেশি পাবে কারেক্ট আনসারে, তাদের মধ্যে ভাগ্যবান 10 জন, তাদের জন্য একটু পুরস্কার থাকবে। সেটা যথারীতি এই আয়োজনে আমরা এসিজি স্টাডি গ্রুপ এবং আমাদেরকে এই ব্যাপারে সহযোগিতা করছে ভ্যাকসিনকো ফার্মা।
আমার মনে হয় ওই ডিক্লারেশনটাও দিয়ে দেন ওয়াদুদ ভাই, যারা আমাদের রেগুলার পার্টিসিপেন্ট তাদেরকে
আমরা আশা করি আরেকটা সুখবর হয়তো দিতে পারবো যে গত প্রায় 1 বছর ধরে আমাদের যে প্রোগ্রামগুলো হচ্ছে তার মধ্যে যারা ফেসবুকে এবং জুমে যারা রেগুলার অ্যাটেন্ড করছেন, আমরা চেষ্টা করছি তাদেরকে ট্যাগিং করার, যদি আমরা বের করতে পারি যারা অন্তত পক্ষে 50% বেশি অ্যাটেন্ডেন্স থাকবে। টুডে ইজ আওয়ার 31st লেকচার। তো সেই হিসাবে যে 50% বেশি যাতে অ্যাটেন্ডেন্স থাকবে তাদেরকে আমরা একটা বই গিফট দেওয়ার কথা প্ল্যান করছি। দেখা যাক সেটা আমরা ইমপ্লিমেন্ট করতে পারি কিনা। তুষার, আমার মনে হয় এখন আসাদের প্রোগ্রামটা আমরা শুরু করে দিতে পারি।
জি স্যার, অফকোর্স। আর আমরা আরেকটা জিনিস জানাতে চাই, সেটা হচ্ছে আমাদের নিয়মাবলী এবং ইসিজি গুলো ফেসবুক পেজে আমাদের এখানে অন থাকবে। Asad sir, you can upload your presentation.
Asad, we cannot see anything as yet.
Yes, sir. Now we can see, sir. Can you see, sir?
No, we cannot see.
স্যার এখন পর্যন্ত স্ক্রিনে কিছু আসছে না, হোয়াইট টোটালি, কার্সার ঘুরছে।
Top share here. Screen share.
এবারে
Yes, sir.
জি জি।
Okay, Assalamu alaikum and very good evening. Thank you, Professor Abdul Wadud Chowdhury, sir, for your kind words. First of all, I'd like to thank ECG Study Group for inviting me to present my cases in this study group webinar. And at first, I'd like to thank our two course directors, Professor Abdul Wadud Chowdhury, sir, and Professor M. Atahar Ali, sir. I welcome all the faculties from home and abroad and all the participants in my today's presentation. Today, my topic is ECG in clinical practice. My first case, am I audible?
Yes, very nicely.
Okay, thank you, sir. My first ECG case, a 26 years old male presented to the emergency department within 30 to 40 minutes of onset of substernal chest pain. He had diaphoresis, shortness of breath, and he was diagnosed a case of acute STMI. He had no known risk factors for ISD, and we planned for primary PCI. Let us see the first ECG at emergency department. Here are some questions in the first ECG. What are the ECG findings and ECG diagnosis? And what could be the differential diagnosis of this ECG? And which is the culprit artery? Is it multivessel or single vessel? Should I proceed or anyone wants to comment on this ECG?
Asad, can I comment?
Yes, sir.
Whenever I see an ECG with
sir.
a presenting with chest pain, what do I look for in that ECG? Obviously, is there any elevation?
Oh,
Yes,
oh, please don't see and show anything. Yeah,
Oh,
let's do it.
I would
Yes.
look for ST elevation or ST depression or T inversion. All these ST T segment changes.
Yes, sir.
The next thing I'll be looking for, is there any Q wave? The third thing I'll be looking for, is there any arrhythmia? Now, whenever I look at a ECG like this, the first impression is that there's some ST elevation obvious from V3 to V6 and to lateral. Now, we have to look around that sector. What about V1, V2? V2 shows some ST elevation, V1 not much, and one AVL, lateral valve ECGs. Those are relatively silent to this extent. But now, what about the inferior valve? It seems the inferior valve also have some problems. 2, 3 AVF, slight ST elevation. Now,
Yes, sir.
that is the problem in here. Now, Asad, take over.
Yes, sir.
So can I make some comments,
Y-
Wadud?
y-
I
y-
agree with you that it could be a wraparound LAD giving this inferior. But more importantly, 26-year-old, if the age is right,
Yes, sir.
then it is of real concern. And I would suggest that we do a differential. But can it be the pericarditis?
Yes.
Looking at EKG, unlikely. But we need to keep that in mind. Another, any history of fever, anything. And then importantly, what about acute pulmonary embolism? Giving this picture is almost unlikely. I can probably rule out that. And then the one important is that, can it be spontaneous dissection? Spontaneous dissection of the coronary or a spontaneous dissection in aortic dissection giving this? We don't know. Is this patient like obese? Any history of hypertension? Doesn't look like that way. Two things I would do at the minimum before going to the cath lab, if possible. One is chest X-ray, and we do the routine blood work, and also a bedside echo before going to the cath lab, because bedside echo would not, and I always say this, the bedside echo does not delay the cardiac procedure. It does not. So I'm sure that you do take to the cath lab, and let's see what we got.
Yes, sir. Should we consider the hyperkalemia in this case as a differential diagnosis?
So hyperkalemia is also in the differential of, but it doesn't look like that way. We have shown you, and usually hyperkalemia, you also see the QRS widening. Tall peak T wave is a differential of hyperkalemia, but with this kind of regional ST elevation puts it off, and the patient has history of chest pain. So you can keep it in your back burner, but it is not in the top 4 or 5 differential. It's not.
Asad,
Yes,
the
sir.
most important concerning thing is that the age. Age is
Yes,
so
sir.
young patient. That's why Hafiz Bhai was first excluding, could it be pericarditis?
Yes, sir.
Because as I have said, both the anterolateral wall and the inferior wall is involved. How that can be? Maybe the LAD is wrap around the apex. That could
Yes, sir.
happen for LAD. But then we should have a look at the AVR. Is there any ST segment depression? And is there any PR segment elevation? There should be. And we should also look to the history, as Hafiz Bhai was saying. Is there any history of fever?
No, sir.
Nature
There's no history of fever, sir.
pain, substernal pain. Is it constricting or stopping, localized, changes with respiration, with deep inspiration, something like that?
It's a very classical presentation of such ischemic type of chest
After
pain, sir.
all these discussion, I would say
sir.
it will be very hard not to take this patient to the cath lab.
Yes.
Yes, sir. Should I move to the next slide, sir?
Yeah.
Yes, sir. We decided to for primary PCI in these cases, as because I have already mentioned there is a very classical presentation of ischemic heart disease. You can see here on the right
Did
side.
you do any echo in the beginning?
Yes,
No.
yes, sir. I will show you later. You can see here on the right side there is a very clear right coronary arteries, and on the left side there is a significant thrombotic lesions in the proximal LAD.
No surprise.
Yes, sir. So next, we move to the direct PCI to the LAD proximal without predilatations. On the left side and on the right side, you can see here there is a clear, but important issue is there is a distal embolizations and there is a occlusions of the distal part of the LAD. There is a clear total occlusions of the distal part of the LAD, sir. So
What did you do about that?
yes, I don't do anything at this moment. I think it's at the terminal part.
I know
there will
this
be
is an
occlusions,
EKG conference, but when you see this kind of thing, what I usually do, I just try the wire.
Yes,
If
sir.
the wire goes, you don't do any balloon or anything. If it is that far, balloon, sometimes if it is little less than apex, you can do a balloon daughtering and then give adenosine or something for the microvascular. You'll see a good flow. Just wire is good enough.
Yes, sir. I cross the wire, but I don't put any balloon across this distal segments.
Yeah. So,
And the next ECG
Is
just after procedure, 2 hours after the procedure, you can see here the ECG.
and it was proved to be correct.
Yes, sir.
This is that's why the inferior wall also had that ST elevation.
Did you think, sir, this is a type 4 LAD or wrapped LAD? As because ST is still elevations in the 2-3 AVF.
yep. You did not, because the apex infraapical portion of the LAD is not revascularized,
Yes, sir.
Still ST elevation in inferior leads a little bit.
Yes, sir. There is still elevations in the 2-3 AVF. So we did a right sided ECG here. And you can see here there is ST elevations in the B5 AVR, that is AVR, ST elevations. So we think that it could be the type 4 LAD and which may lead to the RV infractions. So we did some questions here. Is there any RV infraction? Should we go for the check CAG? Should we wait for 2 to 3 weeks for relook CAG? Is the LAD type 4? This could not be visualized by the distal thromboembolism.
And in this case, actually, I would have gone for wiring and giving intracoronary adenosine or nitroprusside. That will help us to determine whether there is a big type 4 LAD. And the second thing is that you have actually make the LV rather safe. And only part of the LV, the inferior wall, is a little bit damaged. So trying to do too much may be rather harmful.
Yes, sir.
Hafiz Bhai, your comment.
Yeah, I don't see any reason to look for any check CAG because it is probably done deal. The best shot is at the time of the index procedure. And as I said that, for that far, you don't inflate the balloon. If you want to do anything, maximum is balloon daughtering. But sometimes just wiring itself helps. But you need to be lucky enough that you can go through that and blindly you can get some flow. And then RV infarction, the major bulk of the RV is not from this LAD, even if it is wraparound. So if the patient is hemodynamically good and symptomatically, I think is probably pain-free, then I don't see any reason to go any further.
But in this case, I would do another thing. Though it is a ECG webinar, this is a 26 or 28-year-old man without any obvious risk factors. So I would be looking for thrombophilia, underlying cause, why he should have that level of thrombus filled lesion. His other vessels do not seem to have any atherosclerotic changes, that much of it, atherosclerotic.
So, Wadud, maybe we can just say one thing. If, because thrombophilia may involve cost, common things common. For example, if you do lipid panel for this patient and the LDL is 160, then you know what you're dealing with, right? And then you don't need anything further because it looks like looks like to me atherosclerotic plaque rupture related. But if the LDL is normal, like 60, there is no LDL that is immune. But if the LDL is 60, then you need to think about what thrombophilia. Rarely we see paradoxical emboli from the lower leg to the PFO through this. So I will go step by step rather than just throw all the tests at once. It may help save cost. What was the LDL, by the way?
LDL was normal, sir.
Like what number?
LDL probably 135.
So 135 LDL in a 26-year-old is not normal. And by the way, in the lipid profile, we see a bell-shaped curve. So we don't really call anything normal, but in the extreme side or in the lower side, which side? But 135 LDL actually is pretty abnormal in a 26-year-old. So we probably need to aim at lowering the LDL to like 60 down the line.
Okay, sir. So next, move for the next slide, sir. You can see here the echocardiography just after the procedure. You can see their inferior wall is quite okay. There is no wall motion abnormalities along the inferior wall, but there's a mild hypokinesia in the base and mid part of the septum, as well the mild in the apex also. And so this is the ECG just after 2 weeks of follow-up. And you can see here the deep T inversions in the anterior chest leads, as well there is still ST elevations in the 2-3 AVF. So how can you explain these T inversions after this primary PCI within the short period of times?
Is it a sign of a reperfusion injury?
It is already up 2 weeks later primary PCI. So.
And what was the EF at that time, after 2 weeks?
After 2 weeks, EF is quite normal, sir. I will show you the echocardiography just after 2 weeks. I show you the, just the echo just before, just after, sorry. This echo just after the procedure. And the ECG 2 weeks after the primary PCI. And this is the echocardiography just 2 weeks after the primary PCI. You can see here this is quite normal. There is no wall motion abnormality.
That's very interesting.
So if any wall motion we are expecting, it will be infraapical, right?
No, sir, there is no wall motion abnormalities in the infraapical segment, sir.
Yeah, so the EKG evolution with this kind of changes is not uncommon, depending on we have, shifted a lot of debris downstream. So I would go by the clinical part. If the patient is doing good and no issues, then I'm okay. But if the patient is having problem, then I need to explore further. If the patient is doing chest pain free, walking around, exertion, no chest pain, nothing, I probably would not do anything. What is happening with the patient?
Yes, sir. The patient was totally asymptomatic.
Yeah.
And patient was quite stable. But from my point of view, as there is a ST elevations in the 2-3 AVF, I want to do an relook CAG, and you can see here the relook CAG. It's quite good, and the LED is not type 4.
It looks like the LAD reperfused itself.
Yes, sir.
Somewhat.
But LED is not type 4, sir, here. So how can we explain the ST elevations in the 2-3 AVF?
Yeah, but I will tell you after you should be right.
So how much is elevation, Asaduzzaman?
Sir, initially ST elevation was almost 3 to 5 millimeter in the inferior lead, sir. But RC is at this
RC
moment, RC is quite normal, sir.
So
RC
L6. So what do you think? Because the type 4 or not, because
No.
remember that we are defining vessels by the angiogram and
Yeah,
what
yes,
we
sir.
can see. Microvasculature, we don't know.
Yes, sir.
And it is the way your last angiogram was, there was abrupt cessation of flow, looks like cutoff. So
Yeah.
there was a significant, at least some acceptable amount of myocardium we were not seeing from the LAD angiogram, and therefore it is reasonable to believe that there was some blockages and no flow, which over time looks like you have reperfused. But that's why it is important, Dr. Gibson's paper, that type, TME3 flow restoration alone is not good enough.
Yes, sir.
You need to myocardial blast grade, and that ultimately myocardial blast grade is good. That group of patients had the lowest mortality and overall prognosis was good. So, and they're, right coronary good. Usually, in these cases, as I said earlier, if the patient is doing good, I don't do any repeat CAG. You can do another thing that you can do to assure yourself. You can do low-level modified Bruce protocol stress test and see what happens. But usually you don't need to do anything.
Yes, sir. If there is no
Good case.
questions, thank you, sir. If there is no questions for this case, I can move to the second case.
Yes.
Okay, sir. This is my second case, a 46 years old.
By the way, I just wanted
Yes,
to
sir.
tell one
Yeah,
thing.
sure,
It comes in the board. You did the lipid panel following MI. Remember, you did the lipid panel following, and you said LDL 135. So following MI, the lipid panel, if you do, the LDL actually will be lower than it is. We
No,
sometimes
it's
think that it will be higher.
the
That's
initial
why,
assessment, sir.
yeah. The lipid panel
Yeah.
post-MI actually is lower. So later on, if you
Yes, sir.
did it, it will be even higher. It's important because it comes in the board.
Thank you, sir. So this is the second case, a 46 years old non-diabetic hypertensive gentleman came to visit at OPD with history of single episode of chest discomfort, which was relieved by taking liquid antacid. And his ECG and echo were normal, but troponin was significantly raised, 2.1 or 2.3, and he was advised for admission but refused, as he had no symptom for last 2 days. And this is the first ECG at presentations. In the OPD, you can see here the ECG, the first day of presentation. Have any significant change? I think there is no significant change rather than left axis deviation, sir.
I would have done a posterior lead in this patient.
Sir, what are the reasons behind this, sir?
Have you done the posterior lead?
Sir, why, sir?
Whenever you have to raise troponin, that means, but no typical ST elevation, that means it's a non-STMI or a carditis or something like that. One of the guideline-directed dictum is that you better do a posterior lead to exclude that the patient do not have posterior MI. And here in the CCG, V2, that our wave is too much up, tall, and the T is very much upright and very beautiful. They should not be. It's not supposed to be.
Thank you, sir. It's a very important issue, I think, though I understand 2 or 3 days later. So let us see the second ECG, which I advised the patients the second day. Actually, patient came to my OPD on the second day of presentations. So, so the second day of presentations, you can see here the ECG.
What
Having
is the
significant
silent
recurrent-
artery that we are always afraid of? We call it silent because electrocardiographically it may not show, and
Yes, sir.
that was called the circumflex. So if the story is very convincing and EKG is silent, you always worry about circumflex. And if somebody tell you, should I do posterior, you never say no. It's like never say no to coffee. You always, particularly if I rather say it's the opposite. When you see 2-3 AVF changes and you see that precordial also suggestive, and then the resident asked me, should I do posterior? And I said, what for? You already got it. I usually do that for prognostic purposes, posterior and RV involvement, VR, but it is actually more important, as Professor Chowdhury said, that if you are silent, you are scratching your head, then you do the posterior, you'll probably get the bigger thing for the buck. Good.
There is 2 inversions in the second day of the anterior chest leads, but on the first day, it was quite normal. There is no T inversions. Only there seems to be the tall peak T in the B2.
Yeah.
Rather than there is no other abnormalities in the first day, but in the second day, you can see here there is the T inversions and a flat T in the anterior chest leads. So is it means some ischemic involved, or is it indicates that the dynamic changes in the ECG?
I do not like the V4.
Sir.
V4 is evolving into like a biphasic type, you know?
Yeah.
So I don't like. And then it's a 46-year-old with a story of chest pain, and this abnormal EKG is not a good thing.
So
you think of LCX lesions there might be?
Well, we don't know.
Okay, sir.
Because it's just evolving, you know? So usually if you don't see anything, then my bet is, I'm in Las Vegas, I don't like to bet. I'll bet for Cirque. But if it is evolving into precordial like biphasic, then I need to see more. Yeah.
Okay, sir.
next.
So some questions raised in my mind. That's have any important changes between the initial and the subsequent ECG tracing, which I have already shown. And should we consider the patient as ACS, as only raised troponin I and doubtful history without ECG and equivalence of ischemia? And we did 2 echocardiography on the day first and day second, but there is no ischemic evidence of by echocardiography. And what should be the next for these patients? What are the diagnostic criteria for the acute MI?
Let me tell you about the echo, because I'm a great proponent
Yes,
of doing echo at the bedside. Echo normal
Yes, sir.
is not a finding that should assure you.
Sir.
But echo abnormal with the wall motion supports what you're thinking. But echo negative, that should never give you a false sense of security, because subendocardial ischemia may not give you any wall motion abnormality. It may be, it is subtle and may not be of anything to assure you. So that is important thing about echo. Second thing is that doubtful history. History is very subjective thing. I never talk to this patient, but the way you are presenting, it is not doubtful to me. It is very suspicious to me about ischemic origin of chest pain. And along with that, there is raised troponin, and there is no obvious immediate reason for raised troponin,
Yes,
such
sir.
as if this was a 90-year-old with COPD with hypoxia, and then I would have said there is another cause. If there is a trauma patient, I would say there is another cause of, I don't have any obvious reason. GARD or antacid, this will not give troponin. So we are in deep trouble with this history and troponin, and in addition, we are seeing some changes. Any changes is significant.
Thank you, sir. So let us move to the next slides. That is, you can see here the SEC, AHA, ESC, and World Heart Foundation's criteria for the diagnosis of MI. I think all of you know this criteria. There's here you can see the criteria for the diagnosis of MI only when either of the following two criteria, that is one or two, whether there is a raised troponin or cardiac death. These two, either one is sufficient to diagnose the MI, but for the raised troponin, there may be associated at least one of the followings, that is symptom of ischemia, new STT change or bundle branch block, pathological cue on the ECG, new regional wall motion abnormality, or loss of viable myocardium or intracardiac thrombus. So SEC, AHA, and ESC guidelines learning points here, you can see here the ECG is confirmatory for the diagnosis of ACS in approximately 80% of the cases. That is 20% of the patients may be the normal ECG tracing. And cardiac biomarker should be measured, should be measured at presentation due to its superior sensitivity and accuracy. Coronary angiogram can be used to definitely diagnose or rule out the coronary artery disease. And on the early morning, the history of these patients, the patient experienced similar attack on the next day, early morning, which was not relieved by taking antacid. And then he got admitted within the 60 minutes of onset of chest pain. At this time, he was diagnosed a case of acute STMI, and we again planned for primary PCI. And you can see here the ECG, the emergency department. Officer already mentioned this point, that is pectoral fin. This is the looks like a pectoral fin of a shark here. The emergency department patients presented with the severe chest pain.
Due winter statement.
Yes, sir. Yes, sir.
This actually, I agree. This is actually more like a due winters because it goes down and then sharp acute angle. This is almost diagnostic of LAD.
Yes, sir. And this is easy just after entering into the cath labs. You can see here. That is STT change looks like the dorsal fin of a shark.
Did you do any echo at that time?
No, sir.
That's all right. Did you go for primary PCI?
Yes, yes, sir. Just a few brief review on shark fin. Shark fin is an electrocardiographic sign of acute coronary occlusion. It's a unique ECG phenomenon consisting of complex formed by the barring together of QRS and TOFs as a result of extreme ST elevation deviations. Shark fin ST segment elevation is commonly associated with acute LAD occlusion. Many cases go unrecognized and are mistaken for conduction abnormalities, metabolic derangement, and toxicological insult. So we go for the angiography. You can see here there is a significant tight lesions in the PLV, as well there's osteolations in the PDA. And there is a thrombotic lesions that's totally occluded the LAD. So without pre-dilatations, we directly deploy the stents and look at the LAD just after stenting. And this is ECG just after the primary PCI, which was done within 1 hour of presentations, but there is a deep Q waves in V1 to V5.
Now, Asar, can
Sir.
I ask you a question?
Yes, sir.
You have done the primary PCI, you have restituted the blood flow is very good, TB3 flow. But seeing this ECG, the establishment of a full Q-wave television, does it make you unhappy?
It's the question, doubtful questions are actually to me, as because QF may appears within minutes. But I think this should not happen if I did the primary PCI within the 1 hour. It is not expectations to me actually, sir.
Is the presence of Q-wave mean that you do not have any viable myocardium in that area?
No, not sir.
Yes, that's a very important thing.
It's actually a very good point, Wadud, because in the past, you used to call it QMI and non-QMI. But QMI means you are done. Non-QMI means you have hope. But those are not true, because transmural complete MI does not equate with QMI. So you can have Q, still there is a peri-infarct area that you can salvage.
Yeah.
But Q is a bad news. If
Yes,
this
sir.
patient after 6 months, there is a deep Q wave, it's a poor man's way of assessing viability. But we can talk about that another time. But it's not a good news, but it's not as bad news as you may think. And we don't call QMI anymore because of that reason.
We should remember that in patients with Q-wave MI, if it is involves the anterior wall, around 12% patients, the Q-wave will disappear, the R-wave will reappear. In inferior MI, around 25 to 30% cases, the Q-wave will disappear and there will be no Q-wave. Unless you have documented history of the MI, you cannot say seeing the ECG after 2 years or 6 months later on, the patient actually had an MI. So QF do not equate with total loss of muscle. You may salvage muscle there.
Lot of things happening in the microvasculature. And by the way, I just wanted to tell you that the one example that you have given here is actually very good. I would like to have a copy of this EKG. This is a good sign of de winters.
Yeah.
The shark fin classically is described different, which is pre-existing right bundle, if there is any, and then you see the ST segment is massive elevation, typical shark fin. But the dorsal fin not been reported. We are collecting cases. If you have one, the dorsal fin is actually very important to recognize also. So if you are having any dorsal fin EKG, please give it to me. We can do a collection and write it up as a dorsal fin. But excellent case. Thank you.
Thank you, sir. Now we can move to the third case. A 65-year-old diabetic hypertensive lady came for consultations at OPD with complaints of spinning movement of head, shortness of breath, and palpitation for 1 year. After initial assessment, she was advised for admission, but after the admission, patient suddenly developed shortness of breath, and we reinvestigate the patient by ECG, echo, antiproBNP, and troponin I. Look at the ECG, which presented in the OPD.
এটা রফিক স্যার এরিনায় চলে আসছে। স্যার এবার আপনার ECG।
Patient had no history of syncope, pre-syncope, or disease spell, only spinning movement of the head and palpitation.
Here interval are fixed, and every third P wave is conducted. narrow QRS.
PR interval is fixed, but every third P is conducted. Only third P is conducted. Atahar bhai, do you want to make a comment?
I agree with you, Wadud bhai. Actually, high grade AV block, third beat is conducted. 3:1, 1, 2, 3, right?
The patient is
There's the right bundle and left axis.
block and
Bifascicular block pre-existing.
3:1 second degree AV block.
So what would be the ECG diagnosis? It is a 3:1 AV conduction only, or there is a bifascicular block? Should you consider it, or only a single diagnosis?
No. Already right bundle branch block, left anterior fascicular block, as well as AV nodal block, that is 3:1.
Yes,
We
sir.
should mention all the diagnostic points.
Diagnostic.
Asaduzzaman.
Okay, sir. No need of adding the.
But
bradycardia,
why patient
yes.
is short of breath? Patient is rapidly deteriorating?
No, sir. Initially, when she came to the OPD, there is no shortness of breath after admission. This is the OPD ECG, sir. After
Yeah,
admission,
and
she
maybe-
develops sudden
maybe
illness.
I'm thinking too much, but when it's rapid deterioration, always
Right.
think about that, whether there is any ischemic event going on.
Yeah.
And
Yes,
then there is any mitral regurg or anything happening.
Do you think the ST segment in AVR is normal? Chowdhury Hafiz?
I can't see much, but I don't see much, but I worry about this distinct T wave in the V2, because is there any posterior thing happening, so, yeah, and then with the clinical picture, spinning for 3 months, one thing,
1 year,
but
sir.
suddenly getting short of breath, it worries me, whether there is any ischemic event happening. So maybe the story is just unfolding.
Sir.
Can you give us the biochemical parameters, the tropi and antipropion?
Okay, sir. I
How
will
about
show you.
physical exam? Physical exam good?
Yes,
Blood
sir.
pressure good, heart rate good,
Yeah,
pulse
yes,
ox
sir.
good, no
Yes, sir.
murmur,
No,
S3.
sir. No, sir.
Okay, good.
And just ECG after admissions. Admission, you can see here. There's a change in the AV block.
Okay, so
As Hafiz bhai was saying, the patient has right bundle branch block.
Yes,
That
sir.
means he should have T inverted in V1, V2, and perhaps in V3. Here, we are getting an inverted, flattened T in, or inverted, I could say, in V1. But in V2 and V3, there's distinct upright T wave that should not be there. That means there is also a primary ischemic event is very likely in here.
Okay,
So now
sir.
looks
Okay.
like complete heart. Where is Rafique bhai?
Yes, this complete heart block.
Now it's complete heart block.
Yes, sir.
Yeah.
Can you hear me?
Yes, sir. We can hear you clearly, sir.
Somebody with a heart rate of 35 to 36, and you are worried about why the patient is short of breath. I mean, this patient probably isn't. I mean, it's not complete heart block. Before, you see, there is some conduction, 3:1, and then in this ECG, it's also not complete heart block, because if you look at the first RR interval and the second RR interval is different. So it's high grade AV block. And this patient's symptom can be explained by bradycardia itself. And of course, there can be anything else going on. That's different story, what is the underlying pathology for this. How old is the patient?
So, 65 years old lady, sir.
Yeah. I mean, it's a middle, I mean, for Bangladesh, little elderly, but here it's.
Rafique bhai, there is no AV association here. There is AV dissociation, no?
No. But if you look at, okay.
But the PR interval is variable.
Okay, first two intervals. Let's look at the first QRS. There is a P wave before, right? So it may or may not be conducted. Second QRS, definitely not conducted. If it was complete heart block, I would have expected the third QRS exactly the same interval, because that's an escape beat. But it is brought forward. And that is probably brought forward by the P wave before it. And that fits in with the first ECG. Even though you thought that ECG was 3:1, the last but one QRS complex, there is a short RR interval. In that also, there is some degree of conduction, it be, less than 3:1. So it's basically high-grade AV block in this patient. Like, look at this here. After the third QRS, it becomes very regular. And there is probably no AV association. It's probably dissociated. So there's some, at this point, there is probably some QRS complexes that's conducted. The last QRS, you see, last QRS is early. And that probably is a conducted QRS.
But yeah, this, I don't know. Anyway, so it's high-grade AV block or complete heart block, but I don't see any good association. There is evidence of the PR is very, very evolving.
We cannot, the PR, the last QRS is early. You have to have an explanation for that in complete heart block.
Well, it can be ventriculophasic variation.
And a ventriculophasic variation happens to the P wave.
Yeah.
Ventriculophasic.
No, RR can be variable by ventriculophasic.
No, the ventriculophasic term is used for the variation of PP interval in the setting of complete heart block.
Okay.
That's called ventriculophasic sinus arrhythmia. So last QRS complex is early. And I have to have a rational explanation. And one possibility you can say, well, it may be a junctional escape bit, junctional premature bit. That I will buy. But we have to just have an explanation for that. In complete heart block, we should have regular RR interval, not irregular. So the last one, either is conducted or a junctional premature bit. We have to accept one or the other.
Okay, go ahead. Next slide, sir.
Or the patient's management doesn't matter, but I politely disagree with you.
You have to show it to your EP doctor.
Yes,
that,
I am.
That last QRS
I took a picture. I took a picture
you
of it.
Cannot, if it is complete heart block, you have to have an explanation for irregularity. It has to be either a ventricular premature beat in the setting of complete heart block, or a junctional premature beat, or maybe the P wave is bringing the QRS forward. One of those three have to happen to bring it forward.
For the junior doctors, what Sir is talking about, some of the escape bit should be regular on its own, but sometimes we are seeing the QRS complex is coming on early. For example, here first and second, third and fourth, they have equal distance, but the second and third is less time, and that should raise the possibility that some of the P waves may be conducted. That's what Sir is saying. Go on.
Yes, sir. Yes, sir. So ECG show seems to be complete heart block after admissions, and troponin NT-proBNP was significantly raised. And echo showed there is a regional one motion abnormality along the RCA territory, and ejection fraction was 50%. And she was diagnosed a case of NSTMI, complete heart block, and acute left ventricular failure just after admission. And we did the temporary pacemaker immediately and kept under observation for 7 days. We think of there may be an NSTMI along the RCA territory. So we planned for observations under the TPM coverage for 7 days. But initially, the patient was temporary pacemaker dependent, and then she came back to the sinus rhythm. And again, she depended intermittently on temporary pacemaker. And what should be the next? Should we go for the CAG plus minus PCI, or should we go offer for the permanent pacemaker to the party? This is an important issue for me, sir, as well as for the party also.
Sir, I have a question for Rafique, sir. Sir, if the ECG did not show any bifascicular block, only the complete heart block pattern, what should be our approach? And when the ECG shows bifascicular block as well as this second degree or advanced heart block, what should be our approach?
Rafique sir, unmute sir, please.
The question was if it is a bifascicular block versus narrow QRS. It really, from management standpoint, it really doesn't matter because this is not an acute ST elevation myocardial infarction. Now, my issue is that if I have a temporary pacemaker and I'm thinking of further workup, why wait 7 days? Because I have a temporary pacemaker, and if I believe that the patient has ischemic AV block, then I should do the CAT same day or next day. Because by waiting, it's not going to change the underlying etiology. And once I've decided on that,
Same day.
Sir, patient was acutely ventricular failure. There is a gross pulmonary edema on the both lungs, sir.
Hafiz?
So this is a serious issue than just high-grade AV block or complete heart block, whatever you say, because the electrical system is one thing, but there is a more problem than that, ischemia and pump problem, particularly if the chest X-ray and the physical sign is consistent with pulmonary edema. So if the patient is going to the cath lab, I will do everything, because this is very easy to treat in terms of pulmonary edema. Do the the morphine, oxygen, nitroglycerin if possible, because you're putting a temporary wire anyway, and then give diuretics and make this patient comfortable, or even if needed intubated. And definitely one trip to the cath lab for the temporary wire, I definitely would do the coronary angiogram. Definitely.
So,
in the same
what
index.
What you are saying is what I was trying to ask, that you do the same thing same day, right?
Yes,
because,
same time.
Because if there is significant coronary disease, by waiting, it's not going to get any better.
Absolutely, absolutely.
All right, go ahead, please.
Sir, our common belief is that if there is inferior MI and there is a AV nodal, that is the inflammatory changes is there, and if you keep the patient 7 days or 20 or 14 days, then the edema subsided and sinus rhythm usually came back. This is why I asked this question.
Well, you are right, but the problem is that the way that AV block happens with inferior MI is the AV nodal artery gets affected.
Yes, sir.
If there is significant blood flow abnormality, if I wait without doing anything, that is not going to get any better, or even may get worse. Okay. So I would wait. If somebody has an inferior MI and I do intervention and I have a temporary pacemaker, we're going to wait 48 hours or so, and it should come back within 48 hours. If it doesn't come back within 48 hours, it is unlikely, and Hafiz may make a comment on that, about that.
Plumbing first. Plumbing first.
No, but Hafiz, if there is RCA is opened up, how long will you wait before you decide on a patient? 48 hours should be enough, right?
Yes. Yeah. And usually, in this case, if there is no conduction system problem from before, then there is a more chance of coming back. But if there is a conduction system from before already, it may take longer. And usually if there is no pre-existing conduction system, after the reopening, you can wait you can even take a decision in the cath lab itself.
So what did you do? What did you do?
Sir, okay, I want to show you, sir. And just this is after temporary pacemaker. And what I have seen, there is a patient on sinus rhythm day 2 to 5. And then I go for the angiographic view here. You can see here the right coronary artery is quite normal. And on the left side, the left coronary system also normal. There is no coronary abnormalities at this moment.
How do you explain the troponin?
I don't know, sir. For this reason, I want to show this case on this webinar, sir.
One possibility for the raised troponin, was the patient febrile, Asad?
No, at this moment, patient was not febrile. Patient was failure.
Failure. Then there might be some viral myocarditis that might lead to this heart block, as well as raised troponin.
No. Did you do any ventriculogram at this time?
No, sir.
Okay, but you observed some wall motion abnormality in the echo?
In the echo, yes, sir.
So now we know this Minoka MI with no obstructive coronary disease. That's one thing. And we did not have any hemodynamic embarrassment to this patient. No hypoxia, no hypotension. So difficult to explain why the troponin high. And there is no injury pattern with the fever or anything. So there is something in the microvasculature give rise to troponin. There was no other non-cardiac reason in this patient to explain. So it's like, what do you call this? Shakespeare's Hamlet. There is many things in heaven and earth that your philosophers can explain, but something happened to this patient. But good thing that it came back. So one of the things that Rafique Bhai and we are discussing, when there is acute issues like this, and it may be here it is easier. When we go to the cath lab, it is easier to do this angiogram and everything. But what I learned from your case, that step-by-step approach, if you can afford to wait, may not be a bad thing. It probably helped to save some money to the patient also. I don't know about that, but sometimes it is important. But one thing you did a nice job that you excluded there is no significant MR. So if there is a significant MR, I would be really, sometimes you see surprises that there is a pap muscle ischemia rupture and moderate severe MR. That really worries you.
No, sir, there was no MR. Yes, sir.
Actually, what is the troponin level, and whether the troponin level was raised, measured after or before, that is before or after the TPM?
No, before TPM, sir.
And what is the level?
And then you know,
some significantly raised, sir. That's probably
some coronaries reperfused itself, you know. But my question is, and Rafique Bhai and Atahar Bhai, something happened to the conduction system, right? Because now looks like patient is not dependent on pacemaker, right?
Yes, sir. When I did the angiogram, patient was totally dependent on pacemaker. For this reason, we don't wait for another couple of days.
Okay, and then what happened after?
Yes, sir. Then after that, I decided to do the permanent pacemaker.
Oh, okay. So patient never came back to sinus?
No, sir. At the day of 6 or 7, patients was again totally dependent on the temporary pacemaker.
Oh, okay.
Then we decided to do the angiogram. If there is a block, we recanalize the vessel.
Yeah,
and if there is no block, then we go for the permanent pacemaker.
So I was hoping that the patient came back to sinus, or never came back to sinus. Okay.
No. Yes, sir.
Can I make a comment?
Yes, sir.
So the troponin, Atahar asked, how high was the troponin?
Troponin was 2.
2. And what is the cutoff in the lab?
0.1, sir.
0.1.
Yes, sir.
So it's elevated, but not like humongous elevation. Is there one possibility? Is it a lab error? And it can happen anywhere, even here. Number 2, the patient had baseline bundle branch block. So it could have happened 2 ways. One, ischemic event. And if that happened, it will be mainly the anterior vessels, and which is unlikely to come back. I have a comment about this temporary pacemaker. 2 reasons we try to minimize temporary pacemaker duration. 1, the longer you keep, the more is the risk of perforation. And also it increases risk of infection significantly with every passing day. Especially this temporary pacemaker is placed from the groin, right?
Yes, sir.
And the patient has to lie in bed for 7 days. That's the torture. If you do that to me, I will not stay there. I mean, I think about 7 days with the temporary pacemaker in the groin. If for some reason we believe that this temporary pacemaker has to be kept longer period of time, we put it from the top. And now there is a temporary pacemaker which we can actually anchor it so that it does, so that patient can move around. So it's important. So please try to minimize duration of temporary pacing, and if possible, avoid altogether. We try to avoid it as much as possible. And if we think that the patient needs a permanent pacemaker, we do it quickly. So what we would have done in this patient, I would have taken the patient to the cath lab. I would ask the intervention guy to do an angiogram while they're putting the temporary. And at the same time, and the same day, I would have put a permanent pacemaker in, because there is no acute chest elevation to explain. And if the coronaries are normal, there is nothing to wait for. It is going to come back. This case proves that point. That
Agree.
by waiting,
Our problem, Rafique bhai, that we do the temporary wire and angiogram, and then we cannot find an EP guy to put a permanent pacemaker.
that's your center's problem. It's not a problem for us. See?
Particularly
No,
in the
no.
night. Particularly in the
Because-
night, you guys don't come to the cath lab in the night.
Oh, no. I used to do pacemaker at night, but then the intervention guys will say, oh, don't use our lab at night. You are making our staff tired. Anyway, go ahead. This is a good case. Good case. I
Very
think it's
good
an
case.
excellent
Thank you,
case. Excellent
Thank you,
case,
sir.
this one.
But actually, sir, what is the wrong with our learning systems? I want to share you with that. When the patient with MI with acute left ventricular failure without any cardiogenic shock is suspected infra MI, we don't do the cardiac cath at this moment. This is our common learning in Bangladesh. First one. Second one is that if there is infra MI, our teacher told us that keep the patients on temporary pacemaker and wait for 7 weeks, even 2 weeks. So what you have already told, this is the common belief in our Bangladeshi cardiology, sir. For this reason, I want to share this.
No.
Atahar sir, would you comment
No,
on
that-
this issue?
Okay, no, that was true. Even here, when I did my residency in 1991, because there was no primary PCI, and thrombolytics was not widely used. But that has changed completely, because patient comes in and you put the you open up the vessel. So that has changed the scenario completely. And also the traditional teachings, what we are teaching today, we have to reevaluate in a year or two, because medicine is changing so rapidly. We can't wait even for 5 years. And I find it that every time I read, I learn something new, and everything is changing. And of course, every time I talk to Hafiz, I'm very afraid, because he'll teach me something new. He's younger than me.
So Rafique bhai, just to add to your comments, I want to say something. If there is a convincing evidence that there is a STEMI and LV dysfunction, pulmonary edema, of course, you don't have any time. And that is non-compromising. I call it non-negotiable. In that case, you need to give all the therapy for pulmonary edema, but if you're not seeing any response and you think there is a potential impending shock or impending ventilatory failure, then you intubate, go to the lab. But again, it depends on the logistics, what your hospitals are comfortable with. But if it is a STEMI situation, then you need to think very carefully. But if it is non-STEMI, then you need to do the plan that can I treat this by little time, at least hours, get an echo, make sure there is no mechanical problem. If there is a mechanical problem, it's not going to get better. In that case, you need to talk to the family and then your interventionalist and the ICU team that this is not going to get better. This is a mechanical complications. We need to invest a lot more. And please intubate, and then we go then. Cath lab, when you go to the cath lab, things are going to get worse when we go to the cath lab. And that's the worry. But things get worse to get better. So this is a little, controversial thing, not controversial, counterintuitive thing. In the cath lab, we'll give dye, and the EDP will go up, and the patient will crash more. So things are going to get worse. That's why you need to go to the ward fully prepared so that you can tackle that issue. But if you can avoid going in the cath lab immediately, give the full medications, and then see we can buy time, get better, then you can go. But 7 days is too long. For the EP issues, I think 24 hours is a good timeline, but be prepared. But I'm still surprised that how this patient, mechanistically speaking, went into pulmonary edema. I'm still thinking about that. Shortness of breath, subjectively possible, right? With the complete heart block, not perfusing, but going into pulmonary edema and chest X-ray showing pulmonary edema, how that is mechanistically possible. Whether there was a transient ischemia and then went into pulmonary edema possible. Steep ventricle, I don't know.
Did you get any fluid? Did you get a lot
sir.
of fluid in the eye?
No,
Yeah.
no, sir. No, sir.
So this lead, did you put it in the septum?
Yes, sir.
Yeah, that's good. You do it in the LAO and RAO view, what view?
Yeah, yes, sir.
So in the LAO, you can see the septum. So that's a good position. It's a good technique to learn. And once you get used to it, they're pretty stable.
Thank you, sir. May move to the next case, sir?
Yeah,
Please.
beautiful case.
Yes, just after permanent pacemaker, you can see the ECG tracing. Patient was totally dependent on pacemaker.
Do you have the ECG after?
Yes, sir. Yes, sir. After pacemaker, sir.
Yeah, so I'm going to just comment on this ECG. If you, the junior doctors, if you look at the
Yes, sir.
QRS, it is relatively narrow.
So what?
No, I mean, you cannot tell the difference because there is no comparison, but if you did the simultaneous apical pacing, the QRS will be much wider. And
Yes, sir.
so this is relatively narrow QRS because it's septal pacing.
Thank you, sir.
Very well done.
Rafique bhai, will you consider, like, for the sake of discussion, by V pacing? Somebody
Well,
will be too much pace dependent.
The question is whether we should consider bi-V pacing. If the EF is less than 50%, now we are doing more and more bi-V pacing. Definitely less than 40% we will do bi-V pacing. Now we are moving up to 50% because once you put this in, and once the LV function deteriorates, you are kind of in trouble. This patient is less likely because this is a septal pacing. Hopefully this will have less dysynchrony.
QRS is still wide, but we'll see over time what happens.
Thank you, sir.
Asad, next case.
Sir, yes, sir. My ECG case 4, that is a 72 years old gentleman, referred to our hospital with the, yes, sir, with the complaints of severe weakness, palpitation, and shortness of breath for 6 hours, followed by acute watery diarrhea. And he was initially managed in another hospital by cholera saline IV, and he was a known case of hypothyroidism, hypertension, and CKD. His creatinine after admission was 2.9, CPK was 692, troponin was normal, NT-proBNP was raised, chest X-ray show features of bilateral pulmonary edema, and echo was normal. And this is the ECG of this old gentleman just after admissions in a hospital.
Yeah.
But the ECG diagnosis here, what are the findings and what could be the possible etiology of this type of ECG?
Jamil, do you want to make comment?
The ECG looks like a junctional rhythm with a retrograde P-wave falling on the ST segment. And there is one ectopic beat also that probably also around junctional tissue. Also, can I see the patient demographic?
Yeah. Yes.
72-year-old, 72.
Yes,
With
sir.
creatinine of 2. What is the potassium?
Potassium?
Yes, sir. I will come next to the
Yeah.
potassium level. I don't show here that potassium level, sir.
Before your potassium level, Wadud can make comment on that T.
Yeah.
T specialist, T.
She looks like hyperkalemic.
Yeah. Whenever you have a peaked T wave like that, look at the base. Is it wide based or narrow based? If it's
Narrow-based.
always ask for what's the creatine level and what's the potassium level, and look at the QRS complex. And that also helps you to decide whether the patient needs immediate treatment for hyperkalemia or not. I would really ask for the ABG because that gives you the potassium level immediately. But
One thing I want to ask you, because in my experience, I've never seen acute coronary syndrome coming with diarrhea. You know, it's very unusual to have MI and diarrhea. You know, in fact, when I was in ICDDRB, and I go back, I doubt that we have seen patient with diarrhea and at the same time having an MI. I don't know why, but I've never. Have you seen any patients with like active MI and with diarrhea, active diarrhea as well?
We have seen cases of hypotension.
Yes, sir. I have.
Not STD.
Yes, sir. I have also seen.
Like
particularly intra MI and
diarrhea
diarrhea.
with
I don't
MI?
know the reason.
Yeah, because
yes, sir, I have seen
that
in
MI has to be that MI has to be true MI, like not like in this case where the troponin may be positive because hypotension,
yes,
fluid over, and then CKD. So that is you know that is not a convincing MI. The whole world is waiting
actually,
for your
potassium was
level.
very high, 6. Potassium level was 6.9, sir.
I would be asking, yes, sir, Rafique sir. Sir, look at one. There seems to be a after the QRS complex.
What is the question? Yeah, there is a P wave. Those are retrograde P waves.
V1, V2. After the
V1. Yeah, that's a retrograde P wave.
Is it retrograde P wave?
Yes.
Because what I told you it's a retrograde P wave falling on the ST segment.
Yeah.
Yeah.
So because it's present consistently.
Yes, sir.
So our emergency room usually asks us to put a temporary wire in these patients. When we what do you say?
The question is whether to put a temporary pacemaker. I mean, this is a common request. If it is, I put it in if it is less than 30 and the potassium is really high. This is high, but not really high, 6.9. So if you give calcium and the insulin and glucose, hopefully it will change. And that's what they do in the emergency room. And if that doesn't change, then we'll put a temporary in until.
So Rafique, I used to fight with the emergency room. Now I've done a good trick. I said, yeah, we are coming. We'll put a temporary wire. Then we buy time, put a pacer pad, give all the medication for hyperkalemia, and then the rate gets better, and they say, oh, you don't need it now. So.
Yeah, yes, Hafiz, you're right. What if it is like, no, this is what I do. If it is during the day, that's what I do. If it is at 7 p.m., I go and put it in because I don't want to be called in the middle of the night. So, but most of the time, once they give insulin, calcium, and glucose, it gets better quickly.
Yeah.
Okay, good. Interesting case.
Yes, sir, we did it.
You did put a temporary wire or no?
This is some no temporary wire, sir. We managed the patient immediately with the case of hyperkalemia.
Particularly your blood pressure. Patient's blood pressure was good, right?
Stratification of hyperkalemia.
The blood pressure was good. Yeah. If the blood pressure is good and mentation is good,
yes, sir.
You need to argue that, yeah, wait.
Sir.
Asaduzzaman, what beta 2 agonist you used?
Salbutamol, sir.
Salbutamol nebulization works very nicely.
Yes, salbutamol nebulization, less diuretic, calcium gluconate, and calcium resin. And within the very few short period of time, this is the ECG, just after corrections of the potassium. Should we move to the next slide, sir?
Asar, the previous slide, please.
Yes, sir. Yes, sir.
Slide.
This one, sir.
I selected the
first one, sir, or second? Okay, sir.
Previous slide.
না এর পরেরটা মাঝখানেরটা
This one, sir. Oh,
এর পরে যেটা
this one.
Full
This
approach.
one is, this ECG is from another patient, sir. Actually, I have finished my 4 cases and some ECGs
One
here.
of the things, did you give resin to this patient?
Yes, sir.
Well, we are actually moving away from resin, unless it is absolutely necessary, because there is a one significant catastrophic side effect from them trying to find it for the resin. But 6.9, if you give calcium, insulin, glucose, and then of course the patient is temporary, if need be, temporary dialysis, that brings it down. So we are trying to move away from resin unless it is really, really necessary.
Acha, Wadud bhai, I think Asaduzzaman cases are very, very beautiful and nice cases. We should hear from Asaduzzaman the next day, I think.
Okay, sir. I have already completed my cases and okay, sir.
No, actually, your cases are very, very beautiful and really fantastic cases. So I think we'll invite you for the next session. Today, sometimes we can hear from either Rafique sir or Hafiz sir.
It's already late. It's already like you want to continue with him and then
We
finish
can
it off.
an hour. Hafiz bhai, we have half an hour.
Okay.
Hafiz bhai, we can go another half hour. So if you want to show us some ECGs, and we can have a good chat.
Okay, so let me do a rapid fire then. Can I share my screen?
Yes, sir.
Beautiful cases.
I want to stop share here just after complete my last slide. Okay, thank you.
One of the things I tried actually to not show this today because his presentation is so good. You don't go after a good speaker. So let me see whether I can share this. Global leader.
I want to close my sharing.
Okay. Okay. You're good now?
Thank you, sir.
I don't know. Can you see my screen now?
Yes, yes, sir.
Okay, so let me go to the PowerPoint presentation. Can you see my, can you hear me?
Sir, we can hear you, but you're...
We can hear you clearly.
And then you can see my slide set?
No,
no, sir. Only
yes, sir. We can see the list of presentation.
Presentation, yes.
Okay. I don't know why it is not.
So the side effect that I was mentioning about chelating agent is colonic necrosis can happen in sodium polystyrene sulfonate.
Can you see my screen?
No, not the slides. We can see your list.
Okay, so let me stop share. You can see my slide now?
No, sir. Yes, sir.
It's starting.
Yes, chest pain.
Chest pain, okay, good. So this is from two of my fellows, Dr. Chris Susu and Dr. Gibran Rana gave me these cases. So this is a 50-year-old male with chest pain and blood pressure not controlled, and SAT is good, and this EKG, and the troponin was positive. I actually left the hospital, and the fellow got the call from the emergency room to admit under cardiology, and wanted to start on aspirin, heparin, beta blocker, this, that, statin, and then cath whenever we can. So what do you think? So because we do want the audience response, but nobody was participating. So that's why I did not put any questions, but let's discuss. Can you see
Hafiz's screen?
Yeah.
Yes, sir.
Oh.
Can you see, Rafique bhai?
I can see the EKG only.
EKG, right?
Yeah.
So this was the story, and this is the EKG. There is LVH, and there is STT changes, T inversions, right? So I tell the fellows that whenever anybody gives you a case, you always check the data yourself. The troponin number, people usually don't or cannot screw up. But EKG description, you need to see the EKG, and you need to see the primary data. You cannot rely anybody else. You need to look at the EKG yourself. And this EKG he saw, and then he saw, then they said that the X-ray was normal. But I show you the X-ray, and then what is the plan? That cath or giving heparin, do the cath next day. This was the chest X-ray.
We can still see the ECG.
You can see the EKG?
Yeah, you said chest X-ray?
This is chest X-ray. Can you see the chest X-ray?
Chest X is gone again, EKG came back.
Huh?
Now I can see the X-ray.
Yeah.
Oh,
looks like there is a delay.
There is a delay. I can't see the chest X-ray.
Anyone to comment?
Yes.
Yes, aorta is grossly dilated, suggestive of the aortic aneurysm from the chest X-ray.
Okay.
বয়সটা কত?
50.
50.
Uncontrolled blood pressure, hypertensive.
That's the aortic dissection.
Aortic dissection, one possibility, and aortic regurgitation with dilated ascending aorta.
Yeah. So it is not a complicated issue, right? When you see the chest X-ray, but this is what I'm showing you and admitting. This X-ray was reported as nothing remarkable by the weight read of the. This fellow was right. He wanted a CT chest immediately, but let's show you that after the CT chest, the patient was ready to go to the OR because of the dissection. On the way to the OR, patient now got even more chest pain, and the EKG take was there, and EKG was hooked up already. So they wanted a repeat EKG, and this repeat EKG shows this. What do you think going on? So I show you this EKG, right? Mm-hmm. And then the CT done, going to the OR, and this EKG. So Rafique bhai, you will agree that patient looking at the lead 2 is still a sinus rhythm, but there is right bundle and ST elevation and big changes.
Yes. How about AVR? Yeah. Hafiz, are you concerned with the AVR elevation, or is it due to the
Yes, absolutely, Rafique bhai, absolutely. So this patient has dissected into the left main. So immediately went to the OR, and look at this. The dissection is nasty, ascending dissection. And then I don't know if you can see the coronaries. Maybe I can show you. We went back to see. Yeah, go ahead. So this guy was lucky to make it to the OR, and then had extensive surgery, you know. Still in the ICU, he got extubated, but developed a stroke. And we are still struggling. Just to share this case, that you always need to look at the raw data. And the ER resident did not look at the chest X-ray. He looked at the chest X-ray later and was regretting. He was looking at the report. And of course, we told the radiology department that we need to know what the radiologist who said weight reading nothing remarkable. We wanted to know what he was drinking at the time.
Hafiz,
Yeah.
can
Yeah.
I make a comment? The professor that trained me in Japan, he
Yeah.
told me this, that even if you reported it, when you talk about it, look at it again.
Yes.
And
Yes.
you look at your report.
Yeah.
And that was his comment. He said, look at the raw data. You cannot beat that. And that's important. Even if the most knowledge professor sends a report,
Yeah.
you should always look at the raw
And
data.
to tell you, to emphasize that point, Rafique bhai, we do angiogram in the cath lab, and fellow is with me. We read the angiogram as we do it. Then before final reporting in the reading room, we look at the cath again. You would not believe how many times we have found things when you read it again. Sometimes we see myocardial bridges, all these things that we missed out in the original read because we rush, and then we need to look at again, so it's important. So 88-year-old male, frail, and acute worsening shortness of breath, and then he has known myelodysplastic syndrome. We tell this to the fellows that we are cardiologists, but we are also internal medicine docs. Patients' comorbidities are so important to take into consideration, particularly myelodysplastic syndrome. What are the hemoglobin platelets? These are very important because cardiology, particularly interventional cardiology, means we are going to give poisons to the patient. So it is very important that we check out all this. Patient lives with daughter, poor functional. I actually wanted to ask you this, and that's why I'm showing you. Patient presented with this EKG. This is atrial fibrillation, ventricular rate not well controlled. But if you look at the ST segment, deep depression in the precordial leads. And here is your favorite, Rafique bhai. The AVR is also elevated. And so my question is, we all would agree that this is not just AFib, there is more into it, right? And there is a significant issue that there may be coronary disease. My question to you is that what we will do next?
Sir, can I make a comment?
Yeah.
If we have any conduction delay, then the AVR ST elevation is actually not totally valid. Look at lead 1 and lead 2. There are some intraventricular conduction delay. So that AVR elevation I would disregard.
Wadud, I would politely disagree. Other than left bundle, I would still read it. If the ST segment, if in the right bundle, you can still read it. One time, I actually pay less attention to the AVR, and it is also from Olmsted's EKG book. If the patient is exercising, and then you get AVR ST elevation after exercise, without anything else, then it is difficult to interpret. Or there is LVH, then it is difficult to interpret. But if it is not left bundle, in this case, for example, I would pay attention to the AVR because it's a very significant for global ischemia. Because AVR is a neglected lead. It looks at all the other leads. So it was difficult for us, 88-year-old myelodysplastic syndrome comorbidities. And I don't know what to tell you, but we ended up doing cath, but I told the family that, we need a direction. Patient was full code. So we did the cath and then gave the rate control and management, but ultimately EKG came back a little better, but there was significant coronary disease. You can see before we even injected, you see this heavy calcification left main LAD. So the patient ultimately went into pump failure, and we made the patient DNR. So let me show you another EKG. 36-year-old with supraventricular tachycardia came into the emergency room, and this EKG, history of SVT and this EKG. I'm going to go quick.
Heart is around 150.
So Wadud, you are like me. When 150, you think about a flutter, but EP guys tell me not to go by that. And I really follow their advice that if the discernible P wave and then P wave is not like crossing the baseline, no fluttery waves, then don't go to that trap of calling it atrial flutter when actually it is sinus tach.
It does not look like atrial flutter.
Yes, this
Either it's a sinus tachycardia or it may be atrial
The patient has
tachycardia.
history of atrial flutter, so the emergency room was ready to carry over. And then my team went there, and they were not sure, and then they gave adenosine. So I told them, a lot of scientists there. One scientist group was cardioverting, another one was giving adenosine. So this ultimately he was admitted for other reasons, and then this is another episode that happened. Then they got consult from our EP guys, and I will share with Rafique Bhai. But before that, Rafique Bhai, all through it is sinus tach.
Yeah.
And apparently the patient's family saying he underwent 2 ablations. So that made us nervous. What ablation? And this was the discharge EKG. Still looks like sinus to me.
Yes, definitely.
Any thought?
It's sinus.
Can you go back to the?
all-
Can you go to the first ECG?
First EKG, yeah. Can it be like inappropriate sinus tach?
Let's go to the first one.
This is the first one.
Okay, I have a little, because I'm on iPhone, so there is a little delay, so I'll look at it.
Oh,
So I had one patient. She was 30. When I started seeing her, she was less than 30, but I saw her for, and she had what looked like sinus tach.
mhm.
And I even sent her for EP, but they could not find anything. And then she basically developed cardiomyopathy because her heart rate will be like 130, 140.
Mhm.
And then what we found out that she had an atrial tachycardia, which was coming from right superior pulmonary vein.
Mhm.
And that looks exactly like sinus tachycardia.
Yes.
Yes, sir.
And the clue was that it's paroxysmal, but that girl was persistently in that tachycardia. And what confused me was, unlike atrial tachycardia, her rate will go up and down a little bit.
Mhm.
But then she had an ablation, and she's now off all medicine and doing fine. EF has improved. So if you look at lead V1 in this, is a little different from the V1 after sinus rhythm. Now we can say that probably this happened because the rate change distorted the ECG. So in a patient like this, you cannot totally exclude that possibility of an atrial tachycardia.
My issue is, Rafique Bhai, that she's in the hospital. She's lying in a bed. Her
Yeah.
thyroid is normal. She's afebrile. Why she is like sinus tach?
That's what I'm saying. That's what my patient was. Eventually, it turned out to be an atrial tachycardia coming from right superior pulmonary vein, which looks exactly like sinus P wave.
Right.
Because if
So-
you imagine the right superior pulmonary vein, it is sitting just behind where the sinus node is.
Yes, sir.
So this is exactly the reason I'm yeah. Wadud.
The P wave in this ECG in V1 and look at it at the first ECG. They do
Yeah.
not like the same P wave.
Yeah. So what I'm trying to show you, Wadud, exactly that sometimes you think obvious, and then you dig more, and then you wonder, is there anything else? So everybody was like, oh, this is sinus tachycardia. And my issue is that, well, looks like sinus tach, but it doesn't look like flutter. But why is sinus tach on a baseline? So so the saga continues. And because of that theme, I bring this EKG to you, because sinus tach worries me more than anything else. 27-year-old, bipolar, schizophrenia, and then takes medications. Sometimes we don't know. And this EKG, not sinus tach, but this 27-year-old female, this EKG doesn't look normal to me.
PI interval look a little bit shortish.
Short. There is some delta-like wedge.
1 AVL 5-6.
Yeah, V1 also.
And also.
There is some pre-excitation, no doubt.
Okay. And then in the hospital, she does this.
Let's see the second ECG again. Second one. Before the echo.
This one has 2:1.
If you look at V1, it still look like sinus. But then in the hospital, she goes faster. And in the lower panel, I thought this is sinus tach. And the upper panel, I'm not sure.
Yes,
Rafique bhai,
just
upper panel, Athar bhai.
Upper panel, there is TP margin.
Yeah, TP margin.
Yeah.
Or is it, there is a P wave like after?
Yes, QS complex, after QS complex, there is P.
Yeah.
So this is like a retrograde P.
Yeah.
So some kind of AVRT?
Most likely.
So, and then comes to this. Now I'm going to show you that we did an echo. Fellow gave me the echo in between. I wanted to keep it last, but here. So this echo, we thought that this is pre-excitation, maybe association with Ebstein's anomaly and sometimes rarely ASD, who knows? But we got this. That was a surprise. Any thought?
Non-compaction?
There is non-compaction. But is it acquired non-compaction or congenital non-compaction? We don't know. And we were looking at, and let me see what Rafique bhai has to say. And then I'll tell you what our EP guys said. Atahar bhai, do you have any comment?
No, I want to see. No, obviously, pre-excitation.
So, okay. So, I don't know, Rafique bhai maybe not in the line. So it is difficult, Wadud. What we did, we thought that this is almost unlikely to be a ischemic etiology, 27-year-old female. So we started so-called guidelines-directed therapy for LV remodeling, reverse remodeling. And then we are planning to study for the EP, because is it non-compacted LV with cardiomyopathy? There is an association. I have not seen one. We are looking any report. The other thing is that can it be really WPW and then tachycardia mediated cardiomyopathy or not? But maybe it is a too much stretching, but that's our thought. So we'll let you know. And our EP guys, after this, Dr. Gururaj he suddenly kept quiet. He said that I'll study. He doesn't want to commit either way. But his guess is that, I asked him, his guess is that this is right-sided pathway, most likely. So we'll let you know. This 83-year-old hyperlipidemia, hypertension, other comorbidities picked up with the lost consciousness, picked up by EMS, subdural hematoma, and then this EKG. So that EKG to start with, like left bundle, and now this.
Didn't see the EKG.
Here. So left bundle to start with, and now this.
Yeah. Now it is to 1.
Okay. I think unlike the one that Dr. Asaduzzaman showed, and we had a war on high-grade AV block versus complete heart block. By the way, Rafique Bhai is not here. I can assure you that in interventionalist, we care less. High-grade AV block, complete heart block, put a temporary wire, then think about this call EP. So this is, Rafique Bhai will be upset with this, but this is 2:1, right?
Right, exactly.
And then it's changing, he was changing between this and that. And then showing the EKG changes. So what do you do in this situation?
Now, do you think, is there any association with the hemorrhage and the conduction system defect?
Yes, that's why we are showing this. Exactly, Atahar Bhai, because this subdural hematoma getting worse, intracranial pressure rise, patients systolic blood pressure going, a Cushing's effect happening. And this bradycardia getting worse. We told them, you know what? Don't involve us. Address the prognosis first. Sometimes it's the futility of care. So that's the way we dealt with this. Now that tachycardia is an issue, 29-year-old polysubstance abuse, and then thyroid is good. Patient takes tetrahydrocannabinol, EF normal, this EKG. And they are calling us because they gave beta blocker, they could not control it. And then they gave adenosine. Last time they gave adenosine, and I said, did you save the strip? First of all, I did not know why they gave adenosine. Second, I said, even if you gave it, document that what you found. This time they documented. And they are trying to sell to me something else. But I'm still convinced that this is sinus tach. Do you have any other thought?
No. Actually, please show the first ECG.
Yeah, this is the first.
Take ECG, yes. This is the narrow complex tachycardia, and it has got the several differential diagnoses. But first diagnosis should be the atrial tachycardia, and the response after adenosine also supports this atrial tachycardia. Because please next ECG.
So these are all her EKGs.
The late part of the tracing shows the tachycardia, and after adenosine, sinus rhythm, followed by again tachycardia. This is again, that is again supports the diagnosis of the atrial tachycardia. You see the middle part of the stream, sinus, then again the tachycardia returns.
Okay.
The transient termination with the adenosine can happen in case of the atrial tachycardia. So this all support the diagnosis of the atrial tachycardia.
So she turns out to be, she took tricyclic antidepressant as well, sertraline, and then this, but I don't know. I was asking that, will you study this patient?
Yes,
Or
indicated.
you, yeah. Atahar bhai, I wanted to, differ with you because I thought this is all along sinus tach. But when asked our EP guys like you, he said maybe sinus tach, maybe atrial tach, cannot tell. And the adenosine test, like you, he also said that cannot be a proof that it is sinus tach or not atrial tach, because some atrial tach can. Because we hope if it is atrial tach, then atrial tach will continue, but the rate will go down, right? But in some cases, as you said, I think he mentioned 30% atrial tach can be sensitive to adenosine. So it does not prove the point. So I don't know, but this is the EKG that subsequently patient remained okay. And this is the discharge EKG. So, and then they discharged the patient on metoprolol 25 BID, which I absolutely told them to stop, and then follow up with the EP guys. So our Dr. Gururaj saying that he will think about it, whether to study or not. I don't know what it means, but sometimes the EP doesn't answer right away. They always answer right, but they don't answer right away. We have a tendency to diagnose right away and then we jump. But I think the EP guys are very careful. They give a differential and then wait and see. I just wanted to share that sort of a strategy. But I don't see any problem to call it sinus tach, maybe atrial tach. If it recurs, then obviously Atahar bhai, you win without any precipitating factor, and that's why we are doing a telemonitoring. So it's kind of interesting. I will finish with this one, maybe, okay. So 67-year-old with EF good and came in with this. More in the hospital.
Jamil, can you make any comment?
There is, it seems to be supraventricular tachycardia. What is the previous ECG, please?
That looks like sinus to me with maybe non-conducted PSC, like second, third beat.
To me, it looks there is no discernible fluid, and there is some electrical alteration.
Sinus is
bit to bit.
the premature atrial ectopic.
Right. What about the B1? You agree that these are sinus?
This is sinus.
But he goes into this rhythm.
Yes.
So I wanted to show a couple of other things that to the audience actually, that look at the ST changes here. There is no V3, V4, some upsloping ST changes, but not like horizontal or downsloping deep. So I doubt that there is any associated ischemia going on with this EKG, but we called it atrial flutter. Let me show you the story a little more. History of AFib in the past and history of obstructive jaundice, and then this EKG. So, and it was like, we called it atrial flutter actually. And then he came back to sinus with, I actually collected this EKG for Rafique bhai because patient got amiodarone and came back to sinus. I'm sure that he would be mad with this, but I was not too mad actually, because I was okay with short term. There was abnormal liver function test and obstructive picture of the liver function test, and but I did not continue amiodarone and then continue with beta blocker. So, any comment? That's all I have.
What was the age of this patient? Last one?
67.
Not that elderly.
Yeah, not
COPD?
that. No, there is no reported COPD. Yeah. So,
patient
but
for
you know, it's question is, if he survives all that, maybe a good candidate for flutter ablation.
yeah.
But
True.
the EP guys, they don't accept this term AFib flutter. They want to say either AFib or a flutter. But I told them that just try to see whether you can ablate the flutter and see and monitor if the AFib comes back. Because he has a history of AFib and we could not find any old strip to suggest AFib. Sometimes you see things in the patient's record that says AFib, but who knows what was the diagnosis? Unless it's you see yourself, you don't know for sure.
So
Atahar bhai, you can conclude.
So thank you, Chowdhury Hafiz, for your excellent, nice cases and academic cases for today. And I must congratulate our Dr. Khondoker Asaduzzaman for your beautiful academic cases and your brilliant and excellent presentation. You are a good and nice presenter also. And we want to hear from you more and very soon. Asaduzzaman, congratulations. We must
Thank you,
congratulate
sir.
you. Excellent cases that actually you give time to make the preparation.
And
So,
please share the EKG.
Chowdhury, we cannot see you.
Hafiz bhai.
I'm saying that please share the good EKGs as our collection.
Yeah.
Right, exactly. And actually today's Chowdhury Hafiz's cases are also exceptional.
Yeah.
Some cases are really
Yes,
very much academic really. And actually it has it deserves some good academic discussion. And congratulations Chowdhury Hafiz for your excellent brilliant presentation. And I request Chowdhury Wadud to conclude the session as because there is no Firoze. Chowdhury Wadud.
Thank you everybody for staying with us. Nearly 40 people is still with us at this late hour. And we have seen beautiful ECGs and interesting cases. The discussion has been very interactive and very combative as well. And that's
You have no idea if you join our CAT conference. Almost, sometimes it can be, it comes to close to physical, you know.
I really like it. Intellectually, you can fight as much as you wish. And after the fight, let's go to the
Coffee shop.
Have a coffee together. That's the nicest thing about academic dueling. And I hope our audience will enjoy. And all of you audience, if you have a beautiful case and the case scenario interesting, why don't you share with us? Share with either Atahar bhai or myself or Tushar, and we can help you build up the case and present as your own. Or if you want to let somebody talk about it, we can arrange for that as well. But you will be acknowledged as the primary provider of the ECG. And that way, you can contribute as a important part of this growing up session academically. And look at Hafiz bhai. He has been our idol when we were students. We just heard so many stories about him. And that's how we just follow our seniors and to build up ourselves so that our juniors, for them, we can become beacons of knowledge, beacons of idealism, beacons of endeavor. And Peximco, Vidhu Chakpa, Rivu, everyone, so much thanks. So many thanks. You have been with us for 8 or 9 months. There's a tremendous thing you are doing. And
It's our pleasure, sir.
all of you, thank you, sir.
Next Saturday, our presenter is Rafique sir.
Yeah, Rafique sir is our guru. Good night.
Good night.
Good night. Assalamu alaikum.
Anis Awal, Shaila Nabi.
তবে আসাদ আজকে আমার লেট বানানোর জন্য দায়ী, কারণ ও মনে হয় আজকে আগে চলে আসছে, ঠেলে সব রুগী আমার দিকে, আমি পরে থামাইতে বাধ্য হয়েছি। 6টার সময় যে কয়টা রুগী দিয়ে রাখছে ওটা শেষ করতে করতে আমার 8:08 বাজে।
আচ্ছা